See, the topic is about malignancy, especially the carcinoma lung. We know that this is a very dreaded malignancy. And when I was studying respiratory medicine, CLN meant the patient will be over in a year or 2 years' time. And even this period was horrible. He was around the hospital, but not that it didn't work. I have seen myself diagnosing a case of totally CA lung collapsing the whole of the lung, and after a course of chemotherapy it just disappeared on a repeat bronchoscopy. So such things also happen with the standard chemotherapy, but now today the scene is different. It is not taking a biopsy and labeling a patient a CA lung. You have to study for the oncogenic driver alterations like EGFR, ALK1, ROS1, PTF1 for adeno-CA, and PDL1. And there are therapies which are very effective. They are effective in injection form, they are effective in tablet form. And to tell you the truth, a patient of mine whom I diagnosed in 2008 is still living today. And he is on pembrolizumab, and he is still running his business on his own. Surgery for CA lung, I hardly see. Even when you think that you have done everything and the patient is disease-free, after a course of chemotherapy, I'm talking of a friend of mine, after total surgery, full lobectomy, giving chemotherapy, 6 weeks down the line, when the PET scan was done, there were mets in the brain. I don't know why was the surgery done. Only thing was they did not do an MRI brain. They depended upon the PET CT, and MRI brain was not done. Probably he had already the brain mets. Because once it is very small, it metastasizes. That is how the CA lung works. So these therapies, the targeted therapies are really working. And I think we will be hearing Dr. Sajjan, Rajpurohit, and he will be making us wiser about these treatments. Dr. Purohit is a DNB Medical Oncology from Rajiv Gandhi Cancer Institute and Research Center, New Delhi. He is MD Medicine from Maulana Azad Medical College, New Delhi in 2007. He has done MBBS also from Maulana Azad. He has done ESMO Immuno-Oncology, ESMO Neuroendocrine Tumor, and immuno-oncology training from MD Anderson Cancer Center, Houston, USA. He is European Certified Medical Oncologist, ESMO Geneva 2011. He has experience in different kind of cancers. I think I'll ask Dr. Sajjan Rajpurohit to deliver his talk. Thank you.
Can I just request all of you to please maintain decorum throughout the CME, because when we record it and put it on YouTube, there is lot of cutlery noise, which disturbs. And Sushrut always says it is so difficult to edit the meeting. So it's my request, please, don't make noise.
Good evening to all of you, and it is indeed my pleasure to be here amongst this esteemed forum. And at the outset, I'd like to really appreciate and thank you for inviting us here, because very few forums I will actually see that a lot of people are so much interested. Last time when I was doing that CME, there was a kind of interest which has actually motivated me to come back again and be a part of this esteemed gathering today evening. So thank you from the team DLK. And also, sir, for accepting to be moderator here. He's been a friend and a great, I would say, mentor to a lot of medical oncologists across India. So, with this, and Mangla sir, with your permission, I'd like to start the talk. The talk I have kept very simple because I understand there's not have actually evolved in lung cancer, and I can't cover everything which has evolved over the last 5-7 years in lung cancer, but I'll be really, once I finish this talk, I'll be open to questions, and then let's discuss how lung cancer has evolved. So if you see the worldwide data, we all know that lung cancer has been the kind of front runner for cancer In fact, in the terms of mortality, lung cancer is a leading cause of death by cancer worldwide, both in men and women. Dr. Aditya Vidushi will be actually talking about the success story, which is breast cancer. But lung, for last 5 years, we can say we're not a success story, but still we have made a lot of headway. Last, like 2012-13, so we hardly had any drugs. We had like 4 drugs, 5 drugs, and that's what we used to juggle. And we didn't have much. But last 7-8 years, a lot of things have changed in lung cancer. So we come to India. India is really peculiar. We not only smoke tobacco, we chew it. We love tobacco. I think tobacco is a part of our culture more than any other country. So chewing is more important habit in India. That's why head and neck cancers are the most common cancer in men in India. It constitutes the 4th most common cancer in India, and also the 4th most common cancer of death in the Indian data. This is the Global data which we normally refer to. Sir is also right. Hardly in physical or in physician practice you will ever see a patient who is a stage 1 patient. Hardly. It's rare. It's a rare thing. Sometimes when such patients are being evaluated for certain other conditions and they're accidentally diagnosed, that is when we tend to see stage 1 lung cancer. At our center, at BLK Max, we have a multidisciplinary team, and our thoracic oncology program has around 4 to 5 cancer patients every month, which are in early stage or open. But even that is also, I would say, high volume. Normally, people would have less than 1 patient every month in their centers. So, operable lung cancer is now evolving, and also with more and more, especially with the centers like in Delhi NCR, people are more aware. They go for annual checkups. Sometimes people, because of awareness, they get themselves checked. Or on X-rays, they might be diagnosed as some suspicious reason and then further evaluated and found to be the case. So almost, I would say in Indian population, around 10 to 15% patients are early stage, and rest all are advanced. And why it is very important to be early stage in cancer is that in lung cancer particularly, early stage, stage 1, 5-year survivals are 92%, and till now, like very recently, like last time when the data was almost like 3-4 years back, but then that was a longitudinal data. The 5-year survivals were dismal in the tune of around 10% in stage 4. But things are better now. We all know that 90% of these cancers are some form or other related to smoking. Nowadays, we are having some increase in the non-smoking lung cancers also being detected, especially in women and non-smokers. We have certain different type of cancers which are either oncogenic driver mutation originated or related to some other rare conditions like exposure to occupational exposure to either asbestos or radon gas or radiation, or some they're very rarely they are related to family history. Not a very common tumor to have family history. So it's kind of a lifestyle or a personal history of smoking, which is very important as an important lung cancer risk factor. You will also be surprised, it is the doctors who identified this as a risk factor, and there was a last study by Dawn et al. In 1952 when they published. Earlier it used to be norm, like this, nowadays we have this norm of having wine and dine. There used to be a time when physicians, especially surgeons, used to love their cigars. So they rarely ever believed that cigars could be harmful to their lungs. And then this was a British study, almost more than 50,000 physicians came together, and then they determined that yes, there was an actual increase in risk of lung cancer in people who smoked versus who didn't smoke. So it took a lot of physicians and on a concentrated effort to determine whether this is a factor for lung cancer. Coming to the broad types, non-small cell lung cancer is the vast majority. Almost 80 to 85% patients are non-small cell lung cancer, and around 15% patients are small cell lung cancer. Small cell lung cancer is, I would say, a more aggressive variant of lung cancer, and almost always occurs in heavy smokers. So it is almost, you would say that if somebody is a non-smoker, then we should recheck the diagnosis of a small cell lung cancer. Amongst the non-small cell lung cancer, predominantly nowadays the histologies have changed. When I think some of us were in college, the most common histology was squamous cell carcinoma. But over time, probably because of increased use of filtered smoking and refined smoking, I would say. People have gone with moving from BDs or kind of rural tobacco smoking to more refined version where the smoke can go deeper into the parenchyma, and that leads to increased evolution of mostly peripherally situated cancer, which are adenocarcinomas in histology. So 40% of these cancers nowadays are adenocarcinomas, and rest are mixed histologies or large cell carcinomas. Coming to the small cell, we know small cell has in fact much worse prognosis compared to non-small cell cancer, and average survivals have been in the tune of 7 months to 11 months, mostly less than a year. Hardly any progress happened in small cell lung cancer till around 4 to 5 years back. Last 5 years we have now two new drugs which are both immunotherapy drugs known as durvalumab and atezolizumab. They are all PD-L1 inhibitors, and they have had some impact upon the overall survival. I won't say great, but significant clinical improvement in the survivals, which are now ranging. So there are now patients who can have 3 years, 4 years survival in small cell lung cancer, especially in extensive stage, which was otherwise unheard in the last, before 10 years. So this is something which has changed in small cell lung cancer. Still a lot needs to be done in small cell. I think small cell will need more research into the pathogenic evolution of the various mutations which happen in this cancer, and it is one of the poorer prognosis cancers if we just see across the cancers. Coming to the more common variety, which is the non-small cell lung cancer. So as we have mentioned, initially we were only treating based upon histology. Nowadays histology has become less important for our treatment of non-small cell cancer. So like around 2007, 2008, we would either consider them as adeno or squamous, and the treatment will be based upon the adenosquamous. But nowadays, if you just see, as Sir said, we have evolved into molecular diagnosis of these cancers, and histology has become less important. And almost all our patients who are affordable or who are into reimbursable sector, we usually tend to send, apart from the histopathology, a detailed workup for the genetic drivers which are associated, which can include AL, HER, VIRA, PIK3, AKT3, ROS, RET, KRAS, EGFR, and then some other tumor markers in squamous. More in adeno, less in squamous, and all the cancers we also send PD-L1, which is an important marker for treatment decisions in today's world, which is an immunotherapy marker. And you can also see, compared to the small cell data which I showed, in the non-small cell, if you just see, the progress started again similar, but then almost like 5-7 years back. So 2015 onward, we have a lot of indications, and each indication, for example, now we have, for example, even 1 to 2% patients who are ALK positive have now got 5 drugs. EGFR positive have got 4 drugs. So various indications have got a lot of specific targeted drugs being available for a specific type of mutation which happens in these tumors. And even for PD-L1 expression tumors, we have now 3 to 4 agents which are anti-PD-L1 or PD-1 antibodies which are being used into management of such patients. It is very important now that these treatment decisions are taken based upon our tumor board meetings or multidisciplinary meetings, which includes pulmonologists, pathologists, radiologists, medical oncologists, primary care physician, CT-based surgeon, and also in some of the patients, molecular oncologists. So a board sometimes is required to take decisions. In fact, there are patients now who can be offered neoadjuvant chemotherapy and neoadjuvant immunochemotherapy and then taken up for surgery. So it's not like even if currently the patient is a resectable patient, might actually be a good candidate to start with neoadjuvant chemoimmunotherapy and then taken up for surgery. So things are evolving. For each patient we need to have a specific kind of a treatment plan, and I think this is the evolution of precision oncology which has happened, and lung cancer has been one of the front runners into this kind of evolution of treatment decisions. Coming to the stage 1 and 2, mostly localized disease, Sir was right, always check for brain, even if the patient is asymptomatic. Many of these patients will have brain metastasis to begin with. So if a patient is surgically resectable, always evaluate the brain with a brain MRI, and then if everything else is fine, and we are sure that the patient can undergo a R0 resection, these are the patients who would benefit from upfront surgery. Stage 3 is a quite a debatable area. Some surgeons are fond of getting them surgically removed and then putting these patients on adjuvant chemoradiotherapy. Others are more hopeful with chemoradiation followed by adjuvant immunotherapy. So there are certain grey areas in stage 3, but most of us tend to treat such patients with chemoimmunotherapy followed by adjuvant immunotherapy. And stage 1, stage 2 and stage 3, our aim is to cure the patients. So this just show the same thing which I mentioned here. Surgical resection will depend upon where the tumor is located. If the tumor is peripherally located, only one lobe, it's a small tumor, T1, T2 can undergo only lobectomy. A more central location tumor might require pneumonectomy, and some patients might only require wedge resections or segmentomy depending upon how big they are and where they are located. Surgery is the main treatment for early stage patients, and adjuvant treatment is mostly required for almost all the patients. In the case of the most important drug is platinum, usually a cisplatin based doublet, which is given for 4 cycles, and there has been benefit with addition of adjuvant chemotherapy in such patients. So the most important thing is even early stage patients can sometimes fail. So if you just see the 5-year recurrence rate in stage 1B is around 45% and stage 3 is almost 75%. So early stage tumors are also likely to fail, and quite so, and they can fail even in a longer time, and that is where there is also need for even having molecular testing being done early stage patients. And there are patients who are EGFR positive mutation, patients who are in early stage, and they benefit with the addition of targeted drugs even in adjuvant setting. And there have been trials which have shown that there is an improvement in BFS in such patients, and it could be a significant difference between treating such patients with drugs like osimertinib versus not giving them any adjuvant EGFR inhibitor. Coming to unresectable cases, which are the stage 3, and this will include stages which are either like they are mostly they are like T2, T3 or T4, N1, N2 disease, which are the patients which are nowadays being treated with chemoradiotherapy followed by adjuvant immunotherapy by a drug known as durvalumab. And addition of durvalumab has also improved the progression-free survival in these patients. Coming to stage 4 patients, which are the majority of the patients, our goal is to maintain the quality of life and then improve the survival. Again, like to very briefly determine if the patient has some actionable targetable mutation like EGFR, ALK, ROS or other rare mutations, they are likely to be benefiting from not from chemotherapy but from these drugs, whereas other patients who don't have these targeted mutations are more likely to benefit from checkpoint inhibitors, which are PD-L1. So PD-L1 is a receptor which is being expressed on these tumor cells, and if there is an overexpression of this marker on these tumor cells, these can be recognized by the body, and they can undergo direct killing by our body's own immune cells. So if we start giving these antibodies, then they are likely to respond better to immunotherapy. So I've already covered. So there have been evolution of a lot of drugs like EGFR inhibitors starting from first generation, then to second generation, and then third generation. So third generation drugs are very effective. In fact, if you just see the overall survivals have gone to more than 5 years with the third generation, whereas they were in the range of 12 to 15 months with the first generation. So almost tripling of the overall survival with the new class of third generation EGFR inhibitors. Immunotherapy, as I mentioned, so there is an interaction of the tumor cell and the T cell. So T cells are the body's own cytotoxic cells which will go and kill the tumor cell. But what happens that if these tumor cells are expressing this PD-L1, programmed that ligand 1 receptor, and if the T cell goes and interacts. For example, if I just show it here, it's a very important concept because many of you will ask what is immunotherapy. So just see here. So this is a T cell, this is a tumor cell. They will have a ligand known as PD-L1, programmed death ligand 1. So if they are expressing this ligand here,
the T cell will try to go and attach to this ligand. The moment the T cell goes and attaches to this ligand, the T cell will become deactivated. It will, apart from being activated, it will not get activated, it will become energetic. So it will lose its energy and it will undergo apoptosis. So if I am able to block this process by a PD-1 or PD-L1 inhibitor, then these cells are able to live into the tumor milieu and go and hit the tumor cell and kill them. So that's the kind of, so this kind of a checkpoint. So we are having immune checkpoint inhibitors here. So this is the basic pathway which we are blocking with PD-1 or PD-1 inhibitors. And we have now 4 to 5 more immune checkpoint inhibitors which are in trials, and I think next 5 years we'll have more inhibitors like TIM3 or RIM8, and there are other markers which are also being explored apart from PD-1 and PD-L1. So, if a patient's tumor expresses PD-L1 more than 50%, it is very likely to respond to drugs like pembrolizumab or atezolizumab. And even if they have some expression in the range of 1 to 49%, they are also likely to respond to these drugs, but they are more likely to have a more important response to chemo plus immunotherapy. So if a patient has got more than 50% expression, they can only be treated with immunotherapy. They might not require chemotherapy. Whereas if a patient has got expression of PD-L1 1 to 49%, they are more likely to benefit with a combination of chemo plus immunotherapy. So these measurements are important in treatment decisions. So to summarize, the overall 5-year survival in non-small cell lung cancer was around 10 to 15%, but now is in the tune of 25 to 30%, and there are now, all the oncologists have, like 1/4 of patients are able to survive 5 years. So it's a significant jump from the patient which was only 10%, and patients who are on tyrosine kinase inhibitors are in fact likely to have more longer survival. As I said, there's a patient of who was diagnosed in 2008 and still living. So it was almost impossible, but now it is possible. And early stage patients also have additional improvement with adjuvant therapies in the form of radiation, chemotherapy or immunotherapy. And targeted therapies like osimertinib have also made a huge impact, not only in metastatic setting but also in adjuvant setting. And I think that is the way we are going towards more and more precise diagnosis and treatment of lung cancer patients and optimizing their outcomes. So improving lung cancer literacy and awareness is very important. So there is not much we do about lung cancer awareness. In fact, breast cancer awareness has been always a hot topic, and everywhere breast cancer awareness has been, I think the credit goes to ladies. Gents are very compliant. Mostly they are like, even doctors are not very inclined towards having a lung cancer awareness, but lung cancer screening is important, and it is now a part of the American Cancer Society guidelines. So beyond 50 years of age, heavy smokers at least should have a 2-yearly low-dose CT scan which will detect early lung cancers. And enabling early diagnosis for lung cancer can have a huge impact upon the survival, as I mentioned. And what is the role of a physician? Very important. Many times physicians will have a very important role, especially when the family requires diagnosis as well as counseling. And many times patients are like disheartened once they get the diagnosis of lung cancer. So it is our aim to assure them that in right hands they can have much better survival than what normally the historical controls have been there. So high index of suspicion is very important. So one more message before I stop, very important message. Many times, many centers, not here in Delhi, but many centers start ATT for patients who have undiagnosed or suspicious lung or lesion. So my request is that please make them sure that don't go only for FNAC. Sometimes people can have granulous lesions which are just a part of the pathology but not the main pathology. It's always advisable to evaluate patients with PET CT scan at proper biopsy, and then only if the things are negative and it is purely tuberculosis start ATT. But otherwise sometimes people get delayed in their treatment because of empirical ATT. Optimally to refer to a team of oncologists and pulmonologists, and I think if we take the right care, these patients can be managed well. Thank you so much. Thank you so much.
Dr. Poddar sir.
So, Dr. Rajpurohit, you can join here. We will have question answer after the second talk. I think second talk is by a young consultant in medical oncology, Dr. Aditya Vidushi. He is now a consultant in BLK Hospital, medical oncologist. He is a graduate and postgraduate of Maulana Azad Medical College, and then she did his DMB in medical oncology, and she has more than 7 years of experience. At present, she is in medical oncology department of BLK Max Hospital. Previously, she was associate consultant in Artemis Hospital, Gurgaon, and then consultant also for few years in Artemis Hospital. Her areas of interest: breast cancer, lung cancer, and gynecological malignancy. So, Dr. Aditya Vidushi, please, she will speak on early diagnosis and management of breast cancer.
Yes, sir. Good evening, everyone. I feel privileged and grateful for the opportunity of speaking in front of an eminent audience, and thank you, sir, for that very informative talk on lung cancer. So, I'm going to be covering another important malignancy, which is the breast cancer. So, breast cancer, as we know, is the most common cancer among the women worldwide, and it accounts for over 2 million cases every year globally. It is the leading cause of cancer death in women. And when we look at the Indian scenario, we have around 1.5 lakh new cases every year. It is again the most common malignancy in Indian women, and mortality rates globally have declined. As sir pointed out rightly, it is a success story in oncology, and combined overall survival rates of 5-year survival rate of over 90% in stage 1 and 2 we are observing now. Even stage 3 patients, they will have a composite overall survival around 70%, and even in stage 4 cancer, we can expect a 5-year survival of around 30%, which is a good number in oncology. So this has been possible due to the breast cancer screening programs which are more established in the Western world, and also due to the improvement in the adjuvant therapy in form of surgery or in form of chemotherapy and targeted treatments. So looking more closely at the Indian scenario, the age standardized incidence of breast cancer in India is around 25 cases per lakh women. And out of this, we have high mortality, around 12 per lakh mortality is there. When we look at the numbers in Delhi, it is around 40 women per lakh. And as we are diagnosing, as we are getting more experience, it has shown an upward trends over time. This reflects a true increase in the incidence as well as better modalities for diagnosis and more awareness, which has led to diagnosis of more cases. So coming to the risk factors, age is a risk factor. The risk increases with older age. Around 70 to 80% patients are postmenopausal. Here I would like to point out, in the Western societies, the average age of the patient is around 60, whereas in India it is lower. It is around 47, 48, and the cancers that are found in younger patients are more aggressive. The other risk factor is the hormonal factors. Early menarche, late menopause, late age of first childbirth, lack of breastfeeding, and hormone replacement therapy and nulliparity are associated with this cancer. There are certain genetic factors. So around 70% of the cases are sporadic, and these are due to the somatic mutations which are acquired during a person's lifetime. However, 15 to 20% cases we can see a familial clustering. So this familial clustering sometimes, in 5 to 10% cases, it is due to hereditary, inherited genetic mutations. In some other cases, it is due to the shared environmental factors between the families. And a first degree relative of a breast cancer patient has around 2 to 3 times excess risk of developing this cancer. The most common mutations that are associated with this cancer are BRCA1 and BRCA2, which account for around 80% mutations in this subset. And other uncommon mutations include TP53, B10, MSH2, ATM, and certain other mutations. The risk factor is also proliferative breast disease with atypia is also an identified risk factor. Any patient who has undergone radiation exposure in their young age, less than 30 years. Mostly this is the case with Hodgkin survivors. They are diagnosed at an early age and they receive radiation to the chest wall, and hence this can be a risk factor for them developing breast cancer later on. Obesity is another risk factor. Any past history in the opposite breast, any family history of breast cancer, ovarian cancer, fallopian tube or peritoneal cancer is also a risk factor. Now when we talk about screening, there are general population screening and there is genetic screening. So a lot of times patients will come to us and their relatives, their siblings, they will ask us whether they need to be screened for any mutations, because this is a scenario in 5 to 10% patients. So yes, there are indications. If there is a large number of first degree relatives, in patients who are younger than 50 years, if there are 2 first degree relatives with breast cancer, or any age, there are 3 relatives, any patient with bilateral breast cancer should be screened, any patient with a male breast cancer or related with a male breast cancer should be screened, patients with more than one patient relative with ovarian cancer should also be screened. So when we talk about general population screening, so that is the radiological screening that we are talking about. So mammography is the most common screening test here. Sometimes we also use MRI for patients who have a high risk of breast cancer. And the clinical breast examination and breast self-awareness is usually an adjunct to this radiological screening. And the benefit of screening is to find the cancers early, at an earlier stage where they can still be curable and the results are also better. So the guidelines say for patients with average risk, they should start breast self-examination at 20 years. This should be compounded with a clinical breast examination every 3 years from 20 to 39 years. Beyond 40 years, this should be performed annually and this should be combined with a mammogram. And for patients who have a high lifetime risk, MRI is usually the modality for screening. So whenever after a patient comes, we follow the usual algorithms. So patients, a thorough history, physical examination should be done. Then radiological investigations, bilateral breast mammogram is usually the first investigation that we order. For younger patients, sometimes they have dense breasts, so we usually tell them to do an ultrasound and MRI for specific cases. FNAC and biopsy, ER/PR and HER2 status, genetic counseling and fertility counseling for patients of childbearing ages is recommended. So as we all know, the most common symptoms would be usually it is a painless lump, or there is a retraction of the nipple, or there is any discharge from the nipple, any asymmetry in the breast. These can be the warning signs. So the classic mammographic appearance. This will be a speculated high-density mass with an irregular outline. Usually there are certain grouped microcalcifications which are seen. And there is a grading system known as BIRADS, on which all the breast lumps should be quantified. Here I would like to point out BIRADS 0 is not the absence of disease. BIRADS 0 means that it is an inconclusive test and we need to do further testing. If we have used a mammogram, we should do an ultrasound instead, or an MRI. And we need to further evaluate it. BIRADS 1 would be where there is no disease. BIRADS 2 means that it is only a benign disease, it is a fibroadenoma or a lipoma. BIRADS 3 is where the risk of suspicion of cancer develops, and for BIRADS 3 the risk is usually low, it is less than 2%. And these patients should undergo interval follow-up at 3 to 6 months. For any BIRADS 4 or BIRADS 5 lesion, we should do a biopsy straight away. So why MRI is not recommended? Despite it being a highly sensitive test, it is not recommended because it tends to create a lot of confusion because of the false positive results. So this is only indicated if the lifetime risk is more than 20%, or if there is a clinical radiological discrepancy. For example, if we have axillary lymph nodes but there is no radiological mass on the mammogram, if there is a Petit's disease that we can see clinically but there is no breast mass that can be there in the ultrasound or mammogram. Sometimes it characterizes multifocal, multicentric disease better. Invasive lobular carcinoma can also be seen better on a MRI. Also, sometimes when surgeons plan a breast conservation surgery, so to look at the architecture of the breast, it is usually better to do an MRI. But it is only for these indications, and as a routine practice, it should be avoided. Now, for any early breast cancer, additional imaging is not required. It is only required if there are signs and symptoms, depending on the site. So, the National Comprehensive Cancer Network guidelines, they say that if patient has bony pains, if there is raised alkaline phosphatase, do a bone scan. If there are respiratory symptoms, patient should undergo a chest CT. If there are abdominal symptoms, they should do a chest abdomen, CT abdomen. For any patient who already has a locally advanced breast cancer or an inflammatory breast cancer, irrespective of the symptoms being present or not, they should undergo a whole body evaluation in terms of a PET scan. Alternatively, if somehow the PET scan is not available, this can be replaced with a bone scan combined with a CT scan of chest, abdomen, and pelvis. So these are the radiological investigations that we do in the case of breast cancer. Coming to the histopathological diagnosis, so the whole sample is a liquid biopsy. We have to look at the morphology for histology. We have to look at the ER/PR HER2 mu status. These are the receptors that are present on the tumor cells. A Chi-67 and grading has to be done. FNAC unfortunately is not enough for treatment decision making. It has a low sensitivity, and if it is negative, we cannot still rule out breast cancer. It still has a high specificity, so any FNAC which shows malignant disease should be taken seriously, and it has to be compounded by a biopsy. So most common pathologies are ductal carcinoma in 80% patients, others are lobular or mixed metaplastic mucinous medullary are the others. So hormone receptor status is a very important part of classifying the breast cancer. It is very important in the treatment decision making and prognosis. So three most important receptors are the estrogen receptor, progesterone receptor, and the HER2 receptor. And these are diagnosed by special stains, the immunohistochemical stains, and the fluorescence in situ, the FISH testing, the fluorescence in situ hybridization test. So depending on the combination of these factors, breast cancer is a heterogeneous disease. It can be divided into hormone positive disease, which is present in 80% patients. Some patients will have overexpression, which is there in 20% cases, out of which 2/3 are hormone receptor positive and 1/3 are negative. The most dreaded subset is the patient who has ER/PR, HER2, everything is negative. These are called triple negative patients. They are present in around 10 to 15% patients, and the treatment as well as the prognosis in these patients are different. So here I would like to point out the differences between the Western world and India. So in the Western world, around 80% patients will come to us in stage 1, 2 because the screening programs are very robust there. Here, most of the patients in India will present to us in stage 3 and stage 4. The percentage of ER/PR positive patients who are technically the better subset is lower, it is around 60%, and the triple negative subset here is around 25 to 30% patients. So as any cancer, staging is done using the TNM criteria, the T criteria being the tumor size, the M criteria being the nodal numbers, and this gives us a composite stage. So, management is according to the stage. The different components of the management include surgery, chemotherapy. Now we have immunotherapy and targeted agents, radiation therapy and endocrine therapy. And we briefly talking about each. So the sequence for management differs for early breast cancer and locally advanced breast cancer. The stages 1 and 2 are early, and locally advanced includes stage 3, and stage 4 is the one with the metastasis. So I'll be using adjuvant therapy and neoadjuvant therapy. I just want to clarify these terms. Any therapy that is done after the local therapy has removed all the, for example, surgery has been done. Any therapy that is done afterwards is the adjuvant therapy. And this is done in patients who have a high risk of recurrence, and the goal is to eradicate the macrometastatic disease. It is to reduce the local or distant recurrence and to improve survival. This can be in the form of chemotherapy, immunotherapy, or hormonal therapy. The other form of therapy is the neoadjuvant therapy. Now this is the therapy systemic therapy that we do before the definitive local treatment. And this does take care of the micrometastatic disease just like adjuvant therapy, but also it improves operability It improves the cost-effectiveness of the local therapy. For example, if breast conservation surgery is being planned, we can have better results if we give the systemic therapy first. And this also has an important bearing on the prognosis. If the patients are showing good response to systemic therapy that is given before local treatment, that means they are going to fare well later on also. So for early stage, the primary thing is to do the surgery first. It could be in the form of a lumpectomy or a mastectomy, and we have to do a lethal lymph node biopsy, which is followed by adjuvant systemic therapy. Now, adjuvant systemic therapy will depend on whether it is a hormone positive disease, in which case endocrine therapy takes precedence. If there are certain high risk factors, we need to compound it with chemotherapy and also biological therapy depending on the HER2 status. And also adjuvant RT radiation therapy is also done if that is indicated. So, breast conservation surgery, a lot of times patients come to us and they have a question that whether the results are same. So yes, in properly selected patients, the disease-free survival and the overall survival between a full mastectomy and breast conservation therapy are equivalent. But there are a lot of contraindications to do a breast conservation surgery. Patients who have multi-centered disease, who have large tumors, if the disease is diffuse, if there is history of chest RT, if patient is pregnant at the time of diagnosis, because these are the patients who will not be able to take radiation. And patients who have had positive margins despite re-incidence, they are the patients who will not be candidate for breast conservation surgery. For axillary lymph node, we can do a clinical palpation, and if nodes are present, we do a biopsy and do a full axillary node dissection in patients with positive nodes. However, the nodes, if they are negative, we can only do a sentinel lymph node biopsy, and that is usually enough. Adjuvant therapy for hormone receptor positive breast cancer, all patients receive endocrine therapy. But chemotherapy is also indicated patients with high risk characteristics. These include patients who have a tumor size bigger than 2 cm or who have lymph nodes, patients who have high gene recurrence scores and high grade tumors. For triple negative breast cancer, since we don't have any targeted therapy or endocrine therapy also does not work, for them usually chemotherapy is the way to go. Any tumor more than 0.5 cm, we have to give chemotherapy. For HER2 positive cancers, the threshold is more than 1 cm. Now for locally advanced breast cancer, we have to reverse this sequence. This is best managed with multi-therapy therapy. We have to instill the systemic therapy first, we have to give the chemotherapy first, and we have to follow it with the local regional therapy. The important exception here is in the hormone receptor positive disease. For adjuvant therapy, we were choosing endocrine therapy, but here we will rather choose chemotherapy because it has a higher response rate in a shorter time period. For HER2 positive breast cancer and triple negative breast cancer, we will have to start with chemotherapy and HER2 directed agents for HER2 positive disease. Then important principle is that even if patient has a full response to our systemic therapy, they still have to undergo surgery even if the disease has fully disappeared if there is a full response. But patients who are progressing on chemotherapy while undergoing neoadjuvant therapy, they should, instead of switching the chemotherapy regime, we should proceed with surgery. Then once the surgery is done for hormone receptor positive, we don't have to give any further chemotherapy, we can only give endocrine therapy. For triple negative patients, if there is a residual disease, there is something, an oral chemotherapy molecule is available, which we give in the adjuvant setting for a year. And for HER2 positive, we have to complete targeted therapy for a year. Now, why give so much therapy? So the benefit of adjuvant chemotherapy are very well established across different studies, and this is a huge database of around 25,000 patients, and reduced risk of recurrence and reduced risk of mortality has been established for this modality. Of course, this therapy comes with risk. There are a few toxicities including nausea, vomiting, alopecia, myelosuppression and amenorrhea. And there can be long-term toxicities like neuropathy, cardiotoxicity, and rarely they can have chemo-related
Dr. Vidushi, if you will finish, we will have good question answer. Please conclude. 2 minutes you can finish.
Yes, So the timing, we should start adjuvant chemotherapy within 4 to 6 weeks. For radiation therapy, all patients who undergo breast conservation surgery should have radiation therapy, and patients who undergo mastectomy, if they have high risk features, if the tumor size is large, lymph nodes are present and positive margins are present, then they should undergo radiation therapy after mastectomy as well. A brief word about endocrine therapy. So estrogen is a steroid hormone and it promotes the growth of breast cancer by binding to the estrogen receptor. So the essence of the endocrine therapy is either depleting the estrogen or targeting the estrogen receptors. So we have different classes of molecules which can be employed for the same. So main two classes are aromatase inhibitors. We are using third generation, which are super selective inhibitors, and also the tamoxifen. Very briefly about the metastatic breast cancer, which is a stage 4 cancer, which has spread beyond the breast, chest wall and the ipsilateral, the regional lymph nodes. The most common site that we encounter is the skeleton. It is around present in around 40% patients, and these are the patients, if they have bone only less, they have a better prognosis. The other common sites being lung, liver and brain. Hormone receptor positive patients will have maximum metastasis in the bone, and hormone receptor negative patients will have visceral metastasis. Symptoms will be according to the site of metastasis. An important principle is that if a patient has been previously treated, if they present with metastatic disease, they should always be re-biopsied, and the biological markers, the hormone receptor and HER2 status should always be re-established, because this tends to change over time and the therapy decisions then will differ over time. So the treatment goals in a metastatic disease are different. It is not only the prolongation of life, it is the maintenance of quality of life as well, the control of tumor burden and reduction in cancer-related symptoms or complications. And patients, this should be discussed openly with the patient that metastatic breast cancer, although it is incurable, but it is treatable, and a lot of patients can benefit from existing therapies, and they can have overall survival in the range of 50 to 60 months also. So the broad principle of treatment remains the same. For hormone receptor positive, endocrine therapy and targeted therapies are the main agents. Patients who are presenting in visceral crisis should undergo chemotherapy. For HER2 positive, we have anti-HER2 targeted agents. For triple negative, we have chemotherapy, and as I was discussing, immunotherapy is also an option for breast cancer now. So to summarize, breast cancer is the most common malignancy in women worldwide and in India. Early diagnosis and better management is now available because of screening, and multimodality treatment is the most effective therapy. The choice of agent is done as per stage and tumor-related factors. Survival rates and outcomes have improved with the modern treatment modalities.
Very good.
Thank you very much for your time.
Thank you, Dr. You can join here. So I think we will have question and answer session for the first talk by Dr. Sajjan Rajpurohit sir, and I would give the mic to Dr. Amish Vora sir to set the context for his talk, and then one by one you can ask your questions. These are two very important topics. We know that cancers, they have become a very important part and parcel of our day-to-day practice. And despite everything that we know, we must know that the prognosis still remains poor if the diagnosis comes late. So that is the bottom line. You need to diagnose early as possible. Need to take an intervention, whatever intervention you think is possible, or with the help of your oncologist, as early as possible to have a good prognosis. I think Dr. Amish Vora would shed more light.
Thank you, sir. So again, Sajjan is a very, very dear friend. 4 to 5 take-home points from Dr. Sajjan Rajpurohit's lecture. I think please never forget two figures, 92% and 5%. If lung cancer is diagnosed in first stage, there is a chance of 92% patients getting cured as compared to 5% in stage 4. Now, how do we achieve this? He alluded to one study carried out by NCI more than 50 and other high-risk features, once in 2 years, low-dose spiral CT scan reduces the mortality by 17%, 17%. So I think don't miss this chance of getting cured, and please propagate to all your patients that this is a screening method which has been approved. Second thing, what Dr. Sajjan said is that when in 2010, 11, 12, stage 4 lung cancer, small cell or non-small cell, almost 95% of the patients we used to give chemotherapy. 5 ड्रग रहते थे, घुमा फिरा के 1.5 से 2 साल आदमी जिंदा रहता। Now we have modality where only 25% of patients require chemotherapy, 75% do not. Out of these 75%, as Dr. Sajjan mentioned, if you do a proper diagnosis, if you have a tissue sample available, 50% of these people, simple oral tablet में आदमी लंबा 4, 5, 7 साल तक जी सकता है। Immunotherapy is a new wonder drug. The discovery of immunotherapy led to 2 Nobel Prizes back to back 2 years, and it has sort of revolutionized. महंगा है, जैसे मंगला सर ने बोला वैसे महंगा है, but it can definitely make a difference in at least 20 to 30% of patients. If patients who can afford, patients who have the will to live longer with an excellent quality of life, then immunotherapy also is one of the ways of doing it. In fact, Sajjan is very young and dynamic medical oncologist. Sajjan के जैसा ही एक लॉस एंजलिस में एक medical oncologist का इंटरव्यू था, and this is a fact. He said, I don't know last when did I prescribe chemotherapy in lung cancer. So I think important point in lung cancer is tissue and tissue, and awareness. कि भाई स्टेज 4 है तो खत्म नहीं हुआ है। Please make sure that your patient does not lose out an opportunity. Single oral tablet या multiple of tablets से 7 साल आदमी जी सकता है। Stage 4 lung cancer is a very big achievement. I think that is where Dr. Sajjan Rajpurohit wanted to say that. Thank you so much for that.
We will have questions on the first talk. The context having been said by Dr. Amish Vora sir. Dr. Anil Gupta, after a hiatus of 3 years, will have some very good questions.
Sir, at what age we should start screening for lung cancer? Heavy smokers, 50 years or what?
So the guidelines are 50 years, sir.
Yeah.
So normally it takes like anybody normally will start smoking by teenager. Normally the cancer carcinogenesis also takes around 20-25 years. So for smokers, 50 years is the cutoff.
Dr. Vidushi, triple negative is worse than ER negative and PR negative, but HER positive.
Cases will be positive, out of which 1/3 of this would be around, will be only HER2 positive. ER will be negative.
My question is whether suppose somebody is having HER positive but ER negative, PR negative. So that is worst problem, no?
Worst prognosis is triple A.
Her is a very means.
Before the advent of HER2 targeted agent, it was considered a bad subject, but now we have good agents which work against HER2.
Now we have drugs like HER2 positive, so it's not bad. HER2 triple negative is worse.
Thank you very much.
Dr. Rajput, is there any role of screening?
Dr. Rajpurohit.
Sorry, Dr. Rajpurohit. Is there any role of low screening CT in non-smokers?
No, sir.
No.
It's for smokers.
Dr. Rajpurohit still remains Rajpurohit. Please understand.
आपने क्षत्रिय बना दिया।
क्षत्रिय नहीं है, वो राजपुरोहित ही है। Yes, Doctor. Yeah, I can see Dr. S has gone through getting excited. He is our elder brother. Sir, ask your questions gently, sir.
differs from BRCA1 and 2 alleles? And what is the treatment modality for lung? SLPs, ma'am, SLPs are a single generalized group. BRCA1 allele, BRCA2 allele, and SLP. How does it differ from? And what is the treatment modality?
Single nucleotide polymorphism.
SLPs. How it differs from and what is the treatment modality for it? BRCA1 is triple negative. BRCA2 is not triple negative, it can be treated by the hormone therapy. So, then this is the term, this SLP, single generalized, you see, mutation. It also counts in germline, but single mutation. And one more question is there, what are the ecological factors for the somatic genetic mutation of P53 in the breast?
Sir, पहला क्वेश्चन विदुषी के यहाँ पे बोलो. So, sir, SNPs are they can be pathological, they can be physiological. तो अगर pathological होगा, चाहे वो BRCA1 में है, चाहे BRCA2 में है, it has to be treated like a mutant it's a germline mutation which is heritable. So it can affect inheritable or a hereditary cancer which will involve primarily in BRCA1 होगा तो ज़्यादा चांस है कि ब्रेस्ट होगा 80%, ओवरी होगा 40% और मेल्स में भी प्रोस्टेट कैंसर वगैरह हो सकता है, पैंक्रियाटिक कैंसर होता है 10 से 20%. BRCA2 होगा तो थोड़ा लेटर होता है 40% दोनों होता है ब्रेस्ट ओवरी में और बाकी कैंसर थोड़ा देर होता है. तो डिपेंड्स अपॉन व्हिच SNP, whether it is in the actual coding side which is leading to a change in the protein. Many times SNPs cannot be maybe they can be like we can say variant of unknown signature VUS. That's why we have molecular oncology boards where we discuss such cases, sir. तो ये तो डिपेंड करता है कौन सा टाइप का SNP हुआ है.
Another question is this somatic genetic mutation at P53.
Yes, sir. Very important.
What are the etiological factors?
Very important, sir. So somatic will be surprised. Almost 50% of human cancers will have a somatic mutation in P53. P53 is the most important tumor suppressor gene which is responsible, and it is kind of when there are mutation accumulation. Many of our patients very commonly get P53 mutation when we do a gene analysis of tumors. It portrays a poor prognosis for our patients. This means that these patients are less likely to respond to chemotherapy, surgeries and sometimes radiotherapy. So it's kind of a poor prognosis. We still are working on gene therapy for restoration of P53 tumors. It will take some more time.
Dr. Kandu,
germline is very rare. It happens very rarely.
यार simple question. DM वाले question तो डॉक्टर तुलसी के लिए है. आप चलो simple question पूछिए.
The germline mutations are very rare and known as K family syndrome. It happens very rarely.
Sir, let him ask.
हाँ, बगा.
Small cell cancers are more dangerous.
Yes, sir. Yes, sir.
Because they are also having neuron decline.
Yes, sir. Yes, sir. Yes.
So my question is, can this immune checkpoint, this immunotherapy,
yes,
by this targeted T cells, can apoptosis drawn to the tumor cells as the equal, they can equally be effective immunotherapy in small cells?
Okay, sir. I think very valid question. So your question is whether immunotherapy works equally in small versus non-small cell. Yes, it works very nicely in small cell. Only issue with small cell is small cells are more rapidly dividing cells and they are more likely to recur faster than compared to non-small cell cancer. So immunotherapy is now being used in both small cell and non-small cell. But if we compare to small cell, non-small cell is better compared to small cell. But immunotherapy is working, sir.
Sir, we have a question from here. Ma'am will introduce herself, our new member, and she will ask a question. Introduce yourself, ma'am.
Hi sir, I'm Dr. Pallavi, a thoracic surgeon at Sajjan Hospital. I just want to ask you, with the recent advances in lung cancer, would you still refer a patient with solitary brain or solitary adrenal mets for surgery, or do you think that's a thing of the past?
So I think it's actually, mostly if it is going to brain, it is unlikely to be a good prognostic tumor. And you will be surprised, most of these patients will either have a oncogenic driver mutation, either a ALK or an EGFR, or if they are elderly, then a ROS. So these patients might not do well with surgery. I think they are not candidates for surgery. But if they do well over time and they are in good remission once this has been removed, SBRT, local radiotherapy or reduced surgery, could be incorporated for such patients rather than surgery. And that is my personal thing. I think there could be difference of being in surgery.
There's no difference. I think what ma'am, the question you asked is very, very important. It's called as oligometastatic disease. It can be lung, breast, ovary, anything. The most important principle in oligometastasis is stability of metastasis. So if your primary is under control by immunotherapy, target therapy, whatever it is, and your MET does not increase and is under control, then local treatment to that metastasis and the local treatment to primary can result into the word cure for a very few select number of patients. So these patients have to be selected carefully. But you are right, they still 7 to 8% of these patients can be cured.
Sir, we have a question from Dr. Urmil Bansal.
Hi, my question is Dr. Vidushi. What is MR mammography? Is it more sensitive than plain mammography, and when it should be advanced?
Mammography is also one of the latest modality.
It's the latest modality, so just for
Vijay, आवाज नहीं आ रही मैडम की. Ma'am, put it on, ma'am, put it on.
I had already emphasized that for screening purposes, MR should only be, whether it is MRI or MR mammography, should only be judiciously used. But for patients who are already being worked up for diagnosis purposes and we are planning a breast conservation surgery or we have some clinical radiological discrepancy, it can be a very good modality for those patients. For patients who have an occult disease.
But we just had a talk by Dr. Mahajan last week, and he said that MR mammography has a sensitivity of 95 to 100%, and it should be routinely given.
Sensitivity being high will make it a very good modality.
That is when it should be prescribed.
Yes, for diagnostic purposes, for patients who are presenting to us and patients we know are the established cases, for general population screening, probably not a good modality.
In high risk patient, it is a good modality, but it cannot be advised to every patient, but it is costly. Dr. Sajjan.
Yeah, it is costly. 15,000 rupees.
Those who can afford it.
So MR mammography is not recommended for everyone. So only for select population, number one. So screening MR mammography is rarely used nowadays. Only in select population, which has either like family history is positive or we are suspecting in an early age, younger age patient, we are not able to identify what kind of tumor this is. But MR mammography diagnostic, which is also MR with contrast, is being routinely used in early breast cancer patients by our surgeon colleagues, especially when they are planning breast conservation surgery. So both things are different. MR screening mammogram is rarely used. MR diagnostic with contrast is being often used by surgeons to actually define what kind of breast volume is there, what's the breast volume, tumor to breast volume ratio, whether breast conservation will be good for the patient.
So in breast conservation surgery, you have to do MR because you want to be sure in other parts of the breast there is no tumor which has been placed in.
Yeah, I wanted for diagnostic.
Then you have to do it.
Dr. Poddar sir, Dr. Sushruth Ahmed has a question.
Dr. Amish, stage 3, stage 4, once cancer patients are diagnosed and life expectancy of 4 years, 5 years, 6 years, what kind of physical and mental health issues do you experience the patient face during this period and what all is to be done?
For diagnosis also.
Sir, we have a question from Dr. Saxena. Yeah, no problem. Sir, you answer, but then he has a question.
Sir, I think the 3-4 components which you asked, like physical health, definitely in a responding patient, physical health is excellent, sir. Other thing is emotional component or whatever, the psychological impact is really huge because whenever somebody gets diagnosed with stage 4, it's really challenging to keep them in a good physiological health. I think we all have to work together to keep those such patients into good physiological health. So even we try that. Sometimes in India it is difficult to accept a stage 4 cancer diagnosis, even by educated people. So what I and Dr. Amish, I think we have similar practice. We tend to not tell the patient. And unfortunately, many times patient cannot accept it. So we first talk to the family. We also try to gauge to the patient whether that person is really willing to accept that. If we feel the family or the patient will not be able to accept that, it's better to at least keep the patient in a good mood. And but I know, given a choice, I would not have done this, but then sometimes we are bound to. And it's like ignorance is bliss for many people. Third thing is financial health definitely depends on which drugs are being used, whether the patient has got reimbursable or the patient can afford. So affordability becomes a big challenge for drugs like immunotherapy. Long term, the treatments can go up to 1 CR, 2 CR. So I think that kind of help. So one message which I like to pass on, I think Dr. Amish and Ma'am will also agree that insurance पे जरूर ध्यान देना चाहिए आने वाले टाइम में 50 लाख से 1 करोड़ का इंश्योरेंस चाहिए होगा सबको क्योंकि सारे ट्रीटमेंट्स महंगी होती जा रही है and this is one lesson that I have to
My question is, I think if I heard correctly, you said that patient with breast cancer and having lung metastasis
Mike use
50 and 60 weeks.
Mike use.
I think if I heard correctly, you said that patient with breast cancer and having metastasis in lungs can live up to 40-50 weeks. That is about 4 to 5 months.
Volume. Mike नहीं करूँगा.
With lung metastasis. Because I'm getting conflicted. Somebody saying this, somebody saying with lung metastasis 5 years.
Why are you getting conflicted? Nobody said any conflicting. Why are you getting conflicted? Specify your question.
My question is,
you don't believe that they would live longer?
Yeah, that is my question. Breast cancer, lung metastasis, is 5 years survival possible?
Yes. Yeah, in select patient, 30% patient, I tell you, you keep 15 medical oncologists in a queue, ask this question, all 15 will say yes.
In 30% patients, they survive up to 5 years. Even with lung metastasis.
It is possible.
But isn't that paradoxical that with the question isn't that paradoxical that with a primary only 20 to 25% on immunotherapy get to live about 44 years?
No, who said? No, you got it wrong.
I think so there is some slight confusion with survival of lung cancer patient versus breast cancer. Are you talking about both of them?
Yeah, lung primary versus
breast is very routine nowadays. In fact, you'll be surprised. As of now, 75% 5 years survival across all the stages now. It is now 5 years survival. So have improved markedly. So it's very common for us to have patients even not with lung, bone, liver. All these patients survive 5 years. In breast.
So just a minute. We have a question here, sir. No, there will not be any answer. Let us answer the question, please.
Sorry.
Sir, I'm Dr. Shirin, practicing gynecologist. Sir, we as a gynecologist, the patients usually, the female patients come to us for screening of breast cancer. We emphasize on screening. We do mammography, sometimes ultrasound. On routine screening process in mammography, if fibroadenoma, fibrocystic disease has been detected, so we usually advise you to keep in follow-up so that whether it is growing or something. Usually our surgeon counterparts are suggesting them to for resection as a preventive measure. Most of the surgeons are doing that. And we say there is no need of surgical resection. Just keep under follow-up. So, your opinion?
You're absolutely right.
Not able to hear you. Not able to hear you, ma'am.
You're absolutely right.
Mike दूसरा mic use करो.
Not credible.
Can you hear me now? So, ma'am, you're absolutely right. There is no risk of fibroadenoma or fibroadenosis. There is no risk of malignancy. It's a biased 2 lesion. They do not require any oncological thing.
But what about surgical resection?
Surgical resection only if the patient is symptomatic or only if the patient desires to do so. Otherwise, it is not indicated from oncology point of view. No.
No, if it is more than 5 centimeter, we advise resection. Excision biopsy. If it is more than 5, I don't know what is the latest. The surgeons advise excision biopsy of fibroadenoma if it is more than 5 centimeter.
So to have, during my DM exam in 2003, we were taught that fibroadenoma hurts are 1% chance of malignant death. That has been squashed. What she said is absolutely right. Fibroadenoma and fibroadenosis do not get into malignant transformation period. Resection or not resection is scientific versus ethical discussion which we will keep for some other time.
Dr. Rajpurohit has a question.
Hello, sir. Sir, if breast cancer running in the family and every time comes ER positive, can we ask her to remove her ovaries after she complete her family? Is it advisable? Does it help? Hello. So the ideal would be to go for a genetic mutation testing. If the patient is a BRCA1, BRCA2 carrier, they should be offered bilateral salpingo-oophorectomy and bilateral mastectomy. And preferably after, they can be offered at adult age, but preferably most patients should after completion of family, childbearing and family.
I think now we have last 7 minutes. 3.5 minutes both to Dr. Tulsi sir for the DM exam and Dr. M.L. Talra sir to validate it. Over to Dr. Tulsi sir. Sir, please go ahead.
Actually, LDCT we are doing to find out early lung cancer. How much confusion does it create in the mind of patient when you come across several nodules? This patient is living under the fear of cancer. Versus this, how much is the relevance of LDCT?
Sir, I think it's a very valid point. So normally, NDCs will pick up a solitary pulmonary nodule, and again, depending on the size of the pulmonary nodule, if the size is more than 3 centimeters, it is always advisable to that make that nodule undergo excision. Otherwise, they can be short-term follow-up of 6 weeks. You will see how the nodule is evolving. So I think there are different guidelines for the size of nodules. If there are multiple nodules, that's unlikely to be cancer. It's more likely to be pathological. It can be infected. And we can also get a confirmatory PET scan if there is any doubt.
How often should we become, invasive in biopsy? More complications,
So, if there is a suspicious looking lesion, which is at least 3 centimeters, it's advisable to make an undergo resection. We nowadays use VAT surgery, which is much more minimally invasive, and it can help us remove the tumor in toto also.
Wonderful talk, Dr. Purohit. So molecular targeted therapy across all stages 1, 2, 3, A, B, C and 4. Last year the US FDA has approved immune checkpoint inhibitors for preoperative resections, early stage NSCLC and for across all stages as well. Just talk us through this.
Sir, you're right. So last year we got approval for a new adjuvant immunotherapy in lung cancer, and it has found OS benefit with the add of additional immunotherapy in stage 2, stage 3 lung cancers. So it's very exciting time, and I think next 2 to 3 years we will have more and more patients being exposed to new adjuvant chemotherapy and immunotherapy than go for surgery.
So Dr. Mangla talked about, can we request some silence at the back please? Please maintain some dignity. They are still continuing to talk.
Yeah, go ahead sir, go ahead.
Okay, let me proceed. So Dr. Mangla talked about the scanning.
Mic.
So low dose CT scan is what is recommended by the American Cancer Society, American Thoracic Society as well. and they said that you need to do this in people who have moderate to high risk and who have smoked about 24 packs a year. And what about, are you not worried about the false positive as indolent humors may be diagnosed? Tell us, sir.
So any screening program is always not just false positive rates. So that always is a concern, sir. But I think our aim is to pick up early lung cancer patients, and in that scenario, around 10% patients will have a false positive rate, which will have additional testing like VATS guided biopsy or a CT guided biopsy. But I think that cannot be for concern.
My last question to you would be regarding the RAS mutation activation seems to be an independent prognostic factor, especially for early and extensive lung cancer. Talk us through this RAS activation.
KRAS activation.
Yeah.
So, KRAS activation is very, I would say, very peculiar mutation. It almost constitutes around like 40% of common cell. You're talking about KRAS, sir?
Absolutely.
Yes, sir. So, KRAS has been one of the mutations which has long been not targetable, sir. But very recently, we have got now drugs. But again, that drug also has
completing phase 3 trials, which inhibits the AKT protein and will be a landmark moment in the treatment of advanced metastatic breast disease. Talk us through that.
Yes, sir. So CDK4/6 inhibitors are part of NOC guidelines and part of our therapy. We are really prescribing them for metastatic breast cancer that is hormone receptor positive in combination with endocrine therapy. They have large overall survival benefits as well as disease-free survival, progression-free survival benefits. We have 3 agents in this category. We have palbociclib, ribociclib, abemaciclib, which we are using routinely. In addition, there is something called as a PIK3 inhibitor that has also been given for patients who have PIK3 mutation. We have alpelisib. So these are the advances.
Talking about the AKT inhibitors.
The AKT inhibitors are yet to be approved.
This is completing phase 3 trials.
They are yet to be approved. They are not part of the clinical
Thank you, ma'am.
Probably
Thank you.
soon will be.
Thank you.
Sir, take it, please. Sir, let me complete the answer. No, sir, you talked about AKT inhibitors and phase 3 trials. So these are all the DM exam questions what you are asking. My point is, sir, it also has to have a clinical relevance also for the larger audience.
Getting phase 3 trials, so that's what I pointed out. Thank you, sir.
वो हर गाड़ी में एक लाख डब्बा होता है मैं वो I'm impressed with your talk. Very learned colleagues, learned many things. And in very recent WhatsApp University post, I learned about some HRC. Although it's nothing new, I can work it out. It was some startup in Mumbai, some biotechnology. And they are taking a blood sample to see that octamer A4 protein to detect the cancer in early stages. What's your take on that? And how it is based and how it is compared to if we compare to liquid biopsy or synthetic biopsy?
Sir, liquid biopsy is blood. So any blood or any fluid in the body is called liquid biopsy. The liquid becomes biopsy the moment DNA is captured from that. If there is no DNA, then it's a simple practice. There is a basic thing. Now this thing what you are saying in the WhatsApp University, even in the media, there's a lot of hype. My question is very simple, sir. Today, suppose you and I do that test. We have that mutation positive or that protein levels which are high. 1 साल, 2 साल, 4 साल, 5 साल, 10 साल हम कब तक देखते रहेंगे? So the further studies need to be done. It's a first step towards the science. I think maybe in 10 years. अगर आपको याद हो सर, पिछले 15 साल पहले, I am sure you and Tulsi sir know the telomerase concept, right? Telomerase concept, sir. So it is still in the concept phase. So similarly, we have to wait till we get this lab into the edge.
Why I asked this question was to clear my doubt. Because I feel, at times it can be farmer driven or lab driven, that every year you get this test to see where you stand in terms of.
Very valid question, sir. Right now, we have to wait before the mass employment of this test can be done.
What about metformin? Metformin as a adjuvant to cancer. Metformin has been advocated as an anti-cancer medicine. I want to see whether it has been taken up or it is just in between the lines.
Sir, it continues to be in between the lines because there is no concrete trial in any specific cancer type, but there is a hypothesis because it has been seen that people who have got diabetes are more likely to have cancer. So metformin is one drug which can delay pre-diabetic phase, so it can have a preventive role, but we still don't know what's the exact benefit of it.
My last and a half question, sir. It is about are we in a position to, in pipeline, to suggest a breath analytic test like we had for COVID, for alcohol, for cancer? Breath analysis test. I will go through that. Fiction.
I think just a minute. I'll give you time to wind up, sir. Please. We had a wonderful session. I would just like to surprise our wonderful moderators to have their final thoughts on this wonderful CME, Dr. P.K. Mangla, sir. In the last 20 years, do you think the malignancies in the lungs having a good prognosis, the same prognosis, a changing prognosis, a better prognosis, and is there hope for the future? Your comment, sir.
Definitely it is. It's definitely better. In the sense that it was dismal. When I was doing respiratory medicine, severe lung went to the people's lungs. Now patients surviving with tablets or injections, with immunotherapy or targeted therapy and living a quality life. As I told you, the patient lived living since solid state, and managing all his business. You see many more like certainly other patients, even in this era, after having surgery being done, if they are found that they are having mets in the brain, this is another story and dying in a year's time. Regarding the early diagnosis, I just mentioned your case that this patient was a helpless smoker. He was losing his limb but could not leave a cigarette. He had 3 angioplasties but could not leave a cigarette. And he will always come to me because once he came to me with asthmatic symptoms, he got better. In 2-3 years, he got better. And the last time when I saw him, he was not getting better. And finally, we found that he had CLR. When I reviewed his 1-year-old CT scan, it was not a pin or pin head. It was the tip of the organ. That kind of region was there at the same time. Then I thought that probably NDCP might have helped him. So these are certain things I would like to mention, but certainly these days, and Asians have 80%, driver mutations. Europeans and Americans have 60%. We are lucky in that form. If we find one of them, I think we can offer a
Dr. Amish Vora, I would like to ask you, sir, chemotherapy, radiotherapy, immunotherapy in CA lung, which one has changed the game?
Sir, immunotherapy.
Thank you, sir, your short comments. We had a wonderful session from Dr. Vidushi. I just want to ask her, as a physician, and Dr. Kamaljeet Bansal ma'am and Dr. S K Poddar ma'am also asked that question. Ma'am, ultrasound or mammography? Which one? For a physician, For a practicing gynecologist, which one?
So mammogram for most patients, for young patients with dense breast, ultrasound.
Thank you. I would request Dr. S K Poddar sir to summarize the CME, the final CME of Dr. Vidushi.
I think if you can combine both, with many patients they are combining both ultrasound and mammography, but it's still better. But I think that Dr. Vidushi did very good job regarding diagnosis and management of also. She went up to all ERPR positive, HER2 negative, HER2 positive, triple negative. So it was very good. So like very young and very promising medical approach. Very good scheme.
Although I did not understand a word of what Dr. S K Poddar said, what I understand is when caught in confusion, refer the case to Dr. Vidushi. She will sort it out. Okay. We had a wonderful session. All of you agree?
Yes.
Give the moderator